Good afternoon and welcome to the third session of the Icon Amrita E-Gurukul webinar series, which has been designed particularly for the benefit of the DM and the DRNB Medical Oncology exam going students. Today's session will be on drugs used in head neck cancers and CNS malignancies. It is my pleasure to introduce our program director for today, Dr. Vidit Kapoor, who is the Assistant Professor of Medical Oncology, Amrita Institute of Medical Sciences, Faridabad. Sir has done his post-graduation in internal medicine from the University of New Mexico, USA, and fellowships in palliative medicine, medical oncology, and hematology from the prestigious MD Anderson Cancer Center, USA. He has also contributed significantly to oncology research. We have Sir with us today for this webinar, and I will invite him to introduce our moderator for today's session. Over to you, sir.
Thank you so much. Am I audible?
Yes, sir, you are audible, sir.
So yeah, hi, good afternoon, everyone. And it is my privilege to welcome you all today for this third session in the E-Gurukul series, which is an online educational initiative to provide high quality structured learning, not just for students and fellows, but also for practicing medical oncologists, and also to foster a holistic academic environment where we can all learn together. So today's session will focus mostly on drugs used in head and neck and CNS malignancies. Now we all know that these cancers present significant challenges due to their complex anatomy, high rates of morbidity and mortality, and the need for a multidisciplinary treatment approach. So it is extremely important to understand optimizing drug selection, drug sequencing, and combination strategies to improve overall outcomes and to minimize toxicity. And to guide us through this important discussion, we are honored to have with us Dr. Venkata Pradeep, who is a renowned medical oncologist and the Chief Executive Officer at Shankara Cancer and Research Institute at Tezpur, Assam. So without waiting any longer, I would like to invite Dr. Venkata sir to take stage and moderate the session. Thank you so much.
Thank you, Dr. Vidit. Thank you for the kind introduction. And welcome all the students, Dr. Supreet. And today I'm going to introduce our session mentor, Dr. Akhil Kapoor, who is a dear friend and professor in Department of Medical Oncology, Tata Memorial Center, Varanasi, who is doing excellent work along with a lot of clinical trials, and who is a guiding light for many of the colleagues as well as juniors. So Dr. Akhil has mentored Dr. Supreet for the session on the drugs in head and neck cancers as well as the CNS malignancies. And Dr. Supreet is a good friend, and he's a consultant medical oncologist from Sri Shankara Cancer Hospital in Bangalore. Today, he's going to discuss all the commonly used drugs and important indications, the clinical aspects, the precautions we need to take while advising these drugs, and some of the counseling points we need to necessarily make with the patients, and some of the instructions So over to you, Dr. Supreet. And before starting your session by Dr. your session. So over to you, Dr. Supreet.
Thank you.
Dr. Supreet, can you hear me?
Yes, sir. Hello.
Yes, sir, you're audible.
You're audible.
Yeah, thank you, the organizers, for giving me this opportunity. And without wasting much time, I'll start my presentation. Hello.
So, should we share the slides from our end?
Are you able to share your screen, Dr. Supreet?
Yeah. Sorry for the delay. I hope my screen is visible to everybody.
Yes, sir.
Yeah.
Still opening.
So,
Yeah.
so thanks to Venkat sir for kind introduction. So I will be speaking about drugs in head and neck squamous cell carcinoma and CNS tumors today. So first, let us deal with the head and neck squamous cell carcinoma. If you look at various regimens that are used in different clinical situations, in locally advanced situation, there are only two settings where we use chemotherapy. One is induction and the other is concurrent chemotherapy along with radiation. The induction regimen that is approved is docetaxel cisplatin 5-FU. But of course, in clinical practice, we do tend to use other regimens also like paclitaxel carboplatin, or even combining paclitaxel carboplatin with oral metronomic chemotherapy, which is coming up these days. So along with CTRT, we have agents like cisplatin, cetuximab, docetaxel, carboplatin plus 5-FU, which is the approved regimen. But if the patient is too frail, unfit for intense concurrent regimens, we do tend to just use carboplatin as single agent also. In advanced setting, we have extreme regimen, which is cisplatin 5-FU and cetuximab, TP extreme, which is docetaxel, cisplatin, and cetuximab. Keynote 048 regimen, which used platinum, 5-FU, and pembrolizumab, and oral metronomic chemotherapy, which widely followed regimen is methotrexate, celecoxib, and erlotinib. If you look at second line regimens that are approved, it is immunotherapy, which is nivolumab or pembrolizumab, and targeted therapy, which are afatinib or cetuximab. Now, let us look into each of these regimens one by one. To begin with, we look at a clinical case, a 50-year-old gentleman presenting with right buccal mucosal ulcer. His performance status is 1, and he has a swelling that is extending till the right zygomatic arch. And he also has multiple right neck nodes of size 4 centimeters. Now, this patient's stage is CT3N2B, and on biopsy, it was squamous cell carcinoma. So the surgeon had seen this patient first and says that it is borderline resectable and refers the patient to the medical oncologist for neoadjuvant chemotherapy. So as we discussed, the regimen of choice would be docetaxel, cisplatin, and 5-FU. Now, there are various modifications to this regimen which have come up in the later dates, but this is the original regimen which was used in TAX 324 trial, which had docetaxel at a dose of 75 milligram per meter square on day 1, cisplatin 75 milligram per meter square on day 1, and 5-FU 1000 milligram per meter square per day over 96 hours as continuous infusion. Now, one thing that should click to our mind the moment we say DCF is very high rates of serious grade 3, grade 4 neutropenia, which is around 77 to 80% of the patients experience this toxicity. Now, let us look at the drugs one by one. First one is docetaxel. The source of docetaxel, it is a plant alkaloid basically, which is derived from European yew tree, and it is derived from the blades of European yew tree, or the leaves, you can say. And these red colored ones are the seeds of this tree. If you see how it acts, under normal circumstances, when the cell division is happening during mitotic phase, the microtubule assembly happens and they bind to the sister chromatids, and during anaphase, these sister chromatids are, during metaphase, these sister chromatids are drawn towards the poles of the cell, and that results in cell division into 2 daughter cells. Now, what docetaxel does is it binds to the taxane binding site of of already polymerized microtubules. These taxane binding site is located on the beta tubulin of the microtubules. So once it binds, the disassembly or depolymerization of microtubule doesn't happen, and that results in cell cycle arrest and eventually leading to cell death. Therefore, all taxanes are cell cycle specific agents which act in M phase. If you look at the strengths and dilution, docetaxel is available in 20 milligram, 80 milligram, and 120 milligram strengths. The solubilizer, which is used to enhance its solubility, is polysorbate. So nowadays, ready-to-use preparations are also available, which come with already reconstituted solutions, docetaxel solutions, which can be directly mixed into normal saline and used. But previously, we have been getting polysorbate along with the docetaxel. And the most important toxicity of polysorbate is hypersensitivity. And the other solvent is 96% alcohol. So if you see, this is the solvent which contains 2 ml solution of polysorbate plus ethyl alcohol, and the drug is taken, this is taken and added into the drug to enhance its solubility. And once mixed, it is collected through a 21 gauge needle into a 20 ml syringe. We need to remember that docetaxel is a relatively thick solution, so we need to use a larger gauge needle. But it should not be very large because it would end up causing coring through the rubber cork covering the vial, resulting in contamination of the drug. So it should be 21 gauge needle drawn into a 20 ml syringe, and this has to be added into the dilution fluid of 5% dextrose or normal saline. Some people, I use 500 ml as the volume of diluent fluid, but some people use 250 ml. Its stability is around 4 hours at 2 to 25 degrees Celsius. Coming to administration and dose modification, we all know that docetaxel without premedication carries high risk of hypersensitivity reactions. And mostly it is because of polysorbate solvent that is used along with it. So we need to premedicate the patient with antihistamines and dexamethasone. And the administration time is over 1 hour, and it has to be administered through a non-PVC bottle and non-PVC IV set. This is because PVC containing bottles and IV sets are lined or coated internally in their interior surface by a plasticizer called diethyl hexyl phthalate, which is responsible for 2 issues. One, absorption of the drug, which happens by means of the drug attaching to this DHEP, resulting in reduced delivery of the drug and thereby resulting in its reduced efficacy. And the other issue, which is relevant to the current context, is that the polysorbate solvent, which is used in not just in docetaxel, even in paclitaxel, it is used, cetuximab, and a lot of other agents that are used in cancer treatment have polysorbate as a solvent. And this polysorbate tends to leach this plasticizer and take the drug along with it through the IV set, through the cannula into the circulation, resulting in increased risk of hypersensitivity, cardiotoxicity, nephrotoxicity, and it is even shown to be carcinogenic. So to avoid these hazards, we should always use a non-PVC bottle. Now, it is something called a Mira filter set or a codon set, which contains, these are the trade names. It contains ethylene vinyl acetate as the plasticizer. So that does not, it is a neutral material basically, it does not have the problem of leaching or absorption. Now, once the administration has to happen through 0.22 micron inline filter. That again is because of the issue of microbubbles that can form because of the fact that docetaxel and paclitaxel are oily preparations. It also helps in filtering the microorganisms and particulate matter in case there is any contamination, thereby resulting in good drug delivery. Now, if you look at the dose modification, hepatic dysfunction requires dose modification for docetaxel. I think the residents can read up how it is basically modified. It is based on bilirubin level and transaminases. Renal dysfunction does not warrant docetaxel dose modification, but we need to be careful in a patient with pre-existing renal condition while dosing docetaxel, because these patients, if they end up developing diarrhea, which is a common side effect of docetaxel, might contribute to acute kidney injury, causing worsening of renal dysfunction and whole lot of other problems. If you look at the toxicities, you can classify as immediate toxicities, which includes hypersensitivity reactions. If administered without premedication, the incidence is around 20%. It is also a non-DNA binding vesicant. So upon extravasation, it results in serious issues in and around the area of cannulation. And this is not a toxicity of the drug as such, but it is created by improper cannulation or poor monitoring. Short-term side effects include neutropenia, diarrhea, mucositis, palmoplantar erythrodysesthesias, alopecia, fluid retention, and transaminitis. And fluid retention happens because of cytokine release syndrome caused by docetaxel infusion, and therefore we need to post-medicate these patients with dexamethasone. Then long-term toxicities are peripheral neuropathy and pneumonitis. So when asked about docetaxel, these are the side effects that we need to remember, and these are the ones which we encounter also commonly in clinical practice. Now, to eliminate this issue of hypersensitivity reactions and other issues that are happening because of polysorbate, there have been other formulations of docetaxel which have been manufactured. One is a nanosomal docetaxel, which is a lipid suspension. It's a lyophilized solution which is added to the 9 ml of water for reconstitution you get along with the vial, which is added to the vial. It is swirled gently and directly added into the dilution fluid. So it is easy to mix, no premedication required, and it has the advantage of avoiding steroid. And we all know that long-term usage of steroid again creates a lot of problems like hyperglycemia, gastric ulcer, osteoporosis, weight gain, etc. It also has longer stability of around 8 hours to 12 hours as compared to the conventional preparation. And of course, it eliminates the risk of hypersensitivity, as we discussed earlier. Though in clinical practice, I did encounter a couple of cases of mild hypersensitivity reactions, but none of the cases had severe reactions. The other preparation is TPGS docetaxel, which is commercially available in India. It is basically tocopherol polyethylene glycol succinate docetaxel, which again is a preparation similar to dosi-aqualip and can be used without premedication. Coming to the next drug, which is cisplatin. Upon entry into the circulation, cisplatin goes to the cell, cancer cell, and through passive diffusion, it enters into the intracellular space, and also through active transport by means of cisplatin transport receptor. Within this cytosol, it undergoes activation and becomes a positively charged ion. Now, we all know that DNA is a highly negatively charged molecule because of nitrogen and oxygen atoms of the DNA of the guanine bases in the DNA. So these platinum ion, being positively charged, carries high affinity to bind to these negatively charged atoms in the guanine bases, and that results in prevention of DNA polymerase from, because being a heavy molecule, it basically blocks the DNA polymerase from causing further DNA replication and synthesis of a new daughter strand. And also it prevents DNA repair. That is the reason why we tend to see better platinum responses in patients with mismatch repair deficiencies or DNA repair deficiencies in general. Coming to the strength and dilution, it is available at 10 mg and 50 mg vials, 1 mg per ml dilution solution, and dilution fluid is 500 ml of NS. Administration is usually over 1 to 2 hours. Longer duration of administration reduces the risk of nephrotoxicity, and it has a stability of up to 24 hours at room temperature. Now, one common toxicity with cisplatin is nephrotoxicities. So this requires prehydration with 500 to 1000 ml of normal saline, and along with that, we add 20 milliequivalents of KCl and magnesium sulfate 1 gram. Even in post hydration, we tend to add a similar concentrations of KCl and magnesium sulfate. And it is also important to avoid concomitant nephrotoxic agents, especially if the patient gets admitted with febrile neutropenia after giving DCF. We should be avoiding agents like aminoglycosides. And if the patient has pain, better avoid NSAIDs and choose alternative agents. And one point of contention in this area is usage of mannitol, though a lot of centers, including I use mannitol after cisplatin infusion, but there is no strong evidence to recommend usage of mannitol, and a lot of guidelines do not do recommend. Then coming to dosing and dose modification, based on indication, it differs. CTRT regimen, the original trial which studied cisplatin first, which was RTOG 9501, in the definitive CTRT setting, used a dose of 100 milligram per meter square 3 weekly. While there are weekly regimens also which came up later on. There was one trial from TMH which used 30 milligram per meter square, but could not prove non-inferiority as compared to 100 milligram per meter square. Then there were two trials which came in adjuvant and definitive settings, one from Japan and the other from All India Institute of Medical Sciences, New Delhi. Both these could show non-inferiority as opposed to 100 milligram per meter square dosing with 40 milligram per meter square weekly. So 40 mg is the most widely followed dosing strategy concurrent with radiation. Then induction regimens use 75 milligram per meter square, which was used in TAX 323, and 100 milligram per meter square used in TAX 324. Advanced stage setting, we have extreme and TP extreme with two different dosages. Now, cisplatin does not require hepatic dose modification, but renal dose modification is definitely required, being nephrotoxic. And anybody with clearance more than 60 ml per minute, we can administer full doses, but 50 to 60, 75% of the dose. A lot of guidelines say that less than 50 ml per minute using cisplatin should be avoided, but we sometimes tend to use it at 50% dose also, but less than 40 should strictly be avoided. Coming to toxicity, short-term are nausea, vomiting, myalgia, and myelosuppression, especially when it is given concurrent with radiation. So anti-emetic prophylaxis is also important while administering cisplatin. We have to use 5-HT3 antagonist and dexamethasone since it is along with radiation. If it is used at higher doses, we should even use aprepitant or fosaprepitant. Now, dose-limiting toxicities are neurotoxicity, which usually happens at a cumulative dose of 250 milligram per meter square or more. It manifests in the form of sensory neuropathy that includes tingling, numbness, paresthesias. And then gradually it may even proceed to become motor neuropathy. Then ototoxicity happens at doses more than 400 milligram per meter square. The harbinger symptoms are usually tinnitus and high frequency hearing loss. High frequency hearing loss means the impairment of hearing to high pitched sounds. If you take, for example, a female's voice or a child's cry, these are the examples of high frequency sounds to which the patient complains that he or she has more hard of hearing too. Then nephrotoxicity also happens at same cumulative dose, and it is a non-oliguric proximal tubule damage. Therefore, we do not expect these patients, at least during the initial phases of nephrotoxicity, to have decreased urine output. And the harbinger finding that we tend to notice on blood tests is hyponatremia, hypokalemia, which is electrolyte wasting that basically happens because of tubular damage. Then coming to cisplatin ineligibility criteria, this is very important before deciding whether a patient should receive cisplatin or alternative agent. ANS criteria has been used widely in head and neck cancer trials. Absolute contraindications as per these criteria are performance status of 3 or more, creatinine clearance less than 50, ejection fraction less than 50, hearing dysfunction of more than 25 decibels at 3 contiguous test frequencies on pure tone audiometry, neuropathy of grade 2 or more, and CD4 count less than 200. Relative contraindications are performance status 2, creatinine clearance 50 to 60, grade 1 to 2 hearing impairment, and previous cisplatin dose, especially if the patient has received induction chemotherapy and now is planned for definitive CTRT. This is something that we need to keep in mind. And CD4 count 200 to 350 are the relative contraindications. I think 5FU was already covered in the previous schedule, but one thing that I wanted to touch upon, because somebody was asking in the previous session about the role of leucovorin, how it differs when administered along with 5FU or used as a rescue after administering methotrexate. So 5FU is absorbed into the cell, and it binds to, it basically becomes 5-fluorouridine monophosphate, and then 5-fluorouridine diphosphate, and 5-fluorodeoxyuridine monophosphate. This molecule acts as a competitive inhibitor of thymidylate synthase, which basically is an enzyme required for the conversion of deoxyuridine monophosphate to deoxythymidine monophosphate. Basically, deoxyuridine monophosphate is a substrate that is required for DNA synthesis, and thymidylate synthase is the enzyme that helps in conversion of this substrate into DTMP that is required, that forms the first step of DNA synthesis. Now, once this competitive inhibition happens, there is no further DNA synthesis. When methotrexate is administered, on the other hand, it basically inhibits dihydrofolate reductase, and thereby it prevents the conversion of dihydrofolate to tetrahydrofolate, and tetrahydrofolate or reduced folic acid is required for the conversion of deoxyuridine monophosphate to deoxythymidine monophosphate. Now, when methotrexate blocks dihydrofolate reductase, the cell is deprived of reduced folates, and therefore the synthesis of DNA and RNA doesn't happen. Now, after exposure to high-dose methotrexate, when you administer leucovorin acts as an alternative source to reduced folate, and it is basically methylene tetrahydrofolate. So it acts as a source for production of tetrahydrofolate. The cells become available of this substrate, and thereon the DNA synthesis happens. Then coming to the same case, now this patient has received induction chemotherapy, and upon response assessment has a stable disease. Again, you send the patient back to the surgeon, and he says it is still unresectable, and he advises definitive CTRT. So the choice of definitive CTRT in this case would be cisplatin with or without nimotuzumab. Nimotuzumab is an anti-EGFR monoclonal antibody which is manufactured by Biocon in India, and there is a phase 3 trial from TMH which showed overall survival benefit of about 11% at 10 years. So it is one thing which we need to keep in mind, but I would not be discussing about this molecule in detail in the current session. Now, unfortunately, on doing blood test, this patient's creatinine is 2.5 milligram per deciliter and GFR is 40. So we cannot use cisplatin. Therefore, we need to look at alternative agents, which includes cetuximab, docetaxel, carboplatin with 5FU. Then now we want to counsel this patient for cetuximab. We need to know the dosing and cost. I think I don't know if this was covered in the previous session. I just thought I would touch upon this aspect because in head and neck cancer patients, pharmacoeconomics becomes very important because most of them are from low socioeconomic group. So the first dose is administered 1 week prior to starting radiation at a dose of 400 milligram per meter square. Now, if you consider this patient's BSA to be 1.6, his first dose would be 600 milligrams approximately. And each 100 mg of this original cetuximab manufactured by Merck costs around 21,250. Now, 600 mg would come at around 1,30,000, but they have a PAP of 1+1. So essentially, the total price for 6 or 7 doses of cetuximab would be around 3.5 to 4 lakhs. While if you look at biosimilar, which is manufactured by Alkem and also marketed by Lupin, has a price of 10,000 rupees every 100 milligrams. Now, 600 mg would be 60,000, but they do not have any 1+1 PAP. So essentially, it would cost around 3 lakh rupees. Probably there is a difference of 50,000 to 70,000 between the biosimilar and the original molecule. Now, the patient says he cannot afford using cetuximab. So the other options we have are docetaxel and carboplatin plus 5FU. Now, docetaxel has phase 3 trial evidence, which again is from TMH. Here, the doses of docetaxel used were 15 milligram per meter square weekly. Most of the patients will have a round figure dose of around 20 mg, which would be the vial strength that is available. Least vial strength of docetaxel that is available. And cisplatin ineligibility criteria used in this trial are ANS criteria. And when compared against radiation only, docetaxel had shown OS benefit at 2 years. Now, carboplatin as a single agent, though used in frail, old, unfit patients, it doesn't have any randomized trial evidence, only retrospective studies. And it is used at a dose of AUC2 every week. And this was the only big study that I could find when I was doing review of literature for this presentation. And it included 8,290 patients and had shown that after cisplatin, carboplatin is better than cetuximab, but obviously this is a retrospective evidence, so it cannot be taken at its face value. Then carboplatin plus 5-FU has only a phase 2 trial evidence, but the concern with this regimen is high chances of toxicity. It is given at doses of carboplatin is given at dose of 300 to 350 milligram per meter square days 1, 22, and 43. And 5-FU is given at doses of 600 milligram per meter square per day, continuous infusion for 96 hours. Now, this patient receives docetaxel along with radiation, and on performing imaging at 6 weeks, it was found that he still has local disease and lung metastasis now. Now, his performance status is 2, and as per definition, this is a platinum-resistant disease. So, what are the options that we have at our disposal? These are the ones along with their response rate. So, nivolumab, pembrolizumab have a response rate of 13% in second line. Afatinib 10%, low-dose nivolumab plus OMCT. This again was a phase 3 trial from TMH, and it had a response rate of 50%, partly because almost 50% of the patients in this trial were treatment naive, because which means platinum sensitive patients. Then second line chemotherapy regimens include methotrexate. If cisplatin is not used in first line or along with the chemoradiation, that can also be considered as a second line chemotherapy agent, but they have very meager response rates of about 6%, and cetuximab is also approved as single agent with a response rate of 11%. Now, the patient says his daughter's wedding is coming up next month, and he prefers to take less toxic treatment, both financially and physically. So here the regimen of choice would automatically be low-dose nivolumab plus oral metronomic chemotherapy. Now, I was requested by the students to touch upon the rationale behind using low-dose nivolumab and oral metronomic chemotherapy. So, very briefly about it, we know immune checkpoint inhibitors act by blocking PD1 or PDL1 or by blocking the CTLA4. So, when PD1 binds to PDL1, it results in activation of T cell receptor signaling, and thereby inhibits the T cell receptor signaling, and thereby inhibiting further anti-cancer immunity. Now, peripheral T cells which express PD1 are around 20 to 40%. For activation of T cell, the nivolumab receptor occupancy required is around 70 to 75%. Once this occupancy happens at doses of about 0.1 to 0.33 milligram per kg, beyond this dose, whatever may be the escalation, it may not result in higher receptor occupancy and thereby may not increase its efficacy. And it was also found that this receptor occupancy is sustained for about 3 months period. And we also know that the dose response curve of immunotherapy is non-linear as opposed to that of chemotherapy, where we tend to see that the higher the dose, greater are the responses. Coming to oral metronomic chemotherapy, apart from cytotoxicity, it also has anti-cancer effect in the form of anti-angiogenesis that again happens because of inhibition of tumor endothelial cells or endothelial progenitor cells, and by secretion of thrombospondin 1, thereby inhibiting the angiogenesis and vasculogenesis, depriving the cancer cells of nutrition, resulting in cell death. Even immunoregulatory mechanism is another method by which OMCT acts, and this acts by reducing the regulatory T cells or myeloid-derived suppressor cells in the tumor microenvironment, and also increasing the NK cells, thereby increasing the immune surveillance. Now, the rationale behind combining these two agents is The response rates with OMCT is around 40%, but problem with that is that it is very short-living. Response rate with low-dose nivolumab, though it is sustained, it is just around 20%. Now, what we are doing is combining these two agents, one with lower response rates but sustained responses, and the other with little higher response rates but with short-lasting responses. And these agents are combined, and the other advantage of this combination is that it is easy to administer, less toxic, way less toxic than conventional chemotherapy. And the dosing is celecoxib 200 milligram twice daily, plus erlotinib 150 milligram once daily, plus methotrexate 9 milligram per meter square once a week. This is combined with nivolumab 20 milligram once in 3 weeks. Now, one practical aspect here is that nivolumab comes at vial strengths of 40 mg and 100 mg. Now, in the trial, the vial was split between the patients, but in real world practice, we either tend to preserve the vial at 2 to 8 degrees Celsius, or we tend to give the doses of 40 milligram at 6-week frequency, because we also know that the receptor occupancy of nivolumab lasts for 3 months. So that is how we bypass this problem of lesser caseload at low volume centers. Then low dose nivolumab plus OMCT does cause certain toxicities. It is not completely side effect free, but these are far lesser as compared to the conventional chemotherapeutic regimens that we use in head and neck cancers. So anemia is about 15 to 17%. Neutropenia, thrombocytopenia are also less than 10%. Mucositis is also significantly lesser as compared to chemotherapy. But if you look at the trial data, grade 3, grade 4 toxicities were seen in about 50% of the patients. But the incidence of such serious toxicities are lower in real world practice. Now, the commonest grade 3, grade 4 toxicities reported in the trial were hyponatremia, rash, and anemia. Commonest endocrine toxicity was hypothyroidism. Now, these are the drugs. Methotrexate is available at strengths of 5, 7.5, 10, 15, erlotinib 100 and 150 milligrams, celecoxib 100 and 200 milligram capsules, and nivolumab is available at 40 and 100 milligram strengths. It is a clear solution diluted in 100 ml NS and administered over 30 minutes. I think it would be covered in detail in the subsequent session. Now, here we end head and neck cancers, and let us discuss CNS tumors. To begin with the case 40. Hello?
Supreet. Yeah.
Yes, sir.
So it is a very good discussion on head and neck. You have covered almost all important aspects of head and neck cancer drugs. I'd request students to post any questions they have so that we could take the questions later in the part. And Dr. Supreet, please continue with CNS drugs in the CNS.
Yes. So this is a 42-year-old gentleman coming with right-sided weakness. MRI brain showed left parietal lobe lesion of 5 centimeters. Maximal tumor resection was done by neurosurgeon, and it showed grade 2 oligodendroglioma. IHC showed IDH mutated, ATRX retained, Ki67 low, and FISH of 1p19q co-deletion was positive. Now, this is low-grade oligodendroglioma. And this patient received radiation and has been referred to you for adjuvant therapy. Here, the regimen of choice would be PCV for 6 cycles, and it contains procarbazine at dose of 60 milligram per meter square administered from day 2 to day 15, lomustine at 110 milligram per meter square on day 1 at bedtime, and vincristine 1.4 milligram per meter square administered on day 1 and 22, and maximum dose is capped at 2 milligrams. It is a 6-weekly schedule, and it is started 2 weeks post completion of radiation. Now, these are the tests that we need to do at baseline, CBC, RFT, LFT, and also repeated before each cycle. CBC also has to be done on day 22, but vincristine is administered regardless of counts on day 22. But this CBC is useful to decide the dose of procarbazine and lomustine in the next cycle. MRI brain has to be repeated every second cycle. And if you look at the pre-medication, lomustine is a highly hematogenic agent. Therefore, we need to use ondansetron and dexamethasone as pre-medication 30 minutes before giving lomustine. Antihistamine can be given on SOS basis. Now, I would not get into dose adjustments in detail. I have mentioned it in the PPT itself for the benefit of students. Now looking at individual drugs, procarbazine, it is a synthetic compound derived from benzamide. It is used as anti-neoplastic agent starting with MOP regimen, which has been the erstwhile regimen for Hodgkin's lymphoma. And we know that it is an alkylating agent that penetrates blood-brain barrier. We'll just be discussing the general mechanism of action of alkylating agent in the next slide. But one differential mechanism of action of procarbazine is that it produces methyl radicals upon binding to nitrogen residue of guanine. That causes free radical damage to the DNA, and it also produces hydrogen peroxide within the cell, which again causes free radical damage to the DNA. So apart from alkylation, it also causes free radical damage to the DNA. Just thought I would discuss a little bit about history of alkylating agents, because these are the first chemotherapeutic agents to be used in cancer. It was actually derived from a compound called sulfur mustard, which was also called mustard gas, used in World War II as a vesicant. The first picture, we can see that a World War II survivor having his face distorted because of exposure to sulfur mustard causing extreme vesiccation. Now, it was also found that in these patients, there was severe myelosuppression, and also their lymph nodes became hypoplastic. Now, that resulted in observation resulted in the hypothesis by Goodman that these substances can be used in patients with lymphoma, and that's how a lesser toxic derivative of sulfur mustard called nitrogen mustard, also called substance X, whose it was named so because it's the trials on this were kept under the wraps just because of the issues of toxicity, and it was found that this helped a patient with lymphoma. Then Alexander Haddow is the person whom you are seeing in the third image, had hypothesized that cross-linking of DNA by nitrogen mustard is responsible for cell death. And he synthesized mustine, which is the agent that acted as mother to the first alkylating agent that has been used in cancer called chlorambucil, which even today is used in lymphomas, non-Hodgkin lymphomas. So this is the general mechanism of action by which alkylating agents act. They bind to the negatively charged nitrogen atom, mostly on the 7th position of guanine. That results in intra-strand and inter-strand cross-linking, thereby resulting in single-strand and double-stranded DNA breaks, and eventually cell death. Now, this is procarbazine. The toxicities, these are the toxicities in general to all alkylating agents: nausea, vomiting, myelosuppression, mucositis, diarrhea, hepatotoxicity, peripheral neuropathy. But procarbazine causes differential toxicities since it has the ability to blood-brain penetrate the blood-brain barrier, can cause confusion and ataxia. It does not require renal dose modification, but hepatic dose modification is recommended. And it is available in the form of capsules, 50 milligram strength, 10 capsules per strip. It is a part of MOP regimen, which has been used in Hodgkin's lymphoma, BCOP in Hodgkin's lymphoma, De Angelis protocol in primary CNS lymphoma, and PEPSI protocol, which is used as a oral metronomic regimen in relapse refractory non-Hodgkin's lymphoma as a palliative treatment. Coming to the next agent, which is lomustine, the full form of it is also called CCNU. Full form is chloroethyl chlorohexyl nitrosourea. It is a synthetic compound, again an alkylating agent acting by similar mechanism which we discussed earlier. Apart from the usual toxicities of alkylating agents, it causes certain distinct toxicities, which includes pulmonary infiltrates, especially at higher doses, though we will not be used such high doses as a part of PCV regime. But in patients who already have a pre-existing lung condition, we need to be careful. Before starting the patient on lomustine, we need to get the patient's PFT and DLCO checked just the way we do for bleomycin, and it would be contraindicated if the FVC or DLCO are less than 70%. Since it penetrates blood-brain barrier, it also causes ataxia, disorientation. Renal failure is another issue. Myelosuppression, more importantly, thrombocytopenia, that too for sustained periods of time is known with the lomustine. Now it is, that's why there is a gap of minimum 6 weeks between 2 doses of lomustine. And as we discussed, it is very highly emetogenic and therefore requires appropriate antiemetic premedication. Now it is available at 40 milligram strength capsules, 6 capsules per bottle. Coming to next agent, which is vincristine. The source is leaves of Vinca rosea or Madagascar periwinkle tree. Now the mechanism of action of Vinca alkaloids is similar to taxane, but what it does is it prevents the polymerization of beta tubulin to form mitotic spindle, while taxanes prevent the depolymerization. Therefore, this causes cell cycle arrest in M phase and eventually cell death. If you see the available strengths, it is 1 milligram per ml vial, single strength. It is given through 22 gauge IV cannula, a blue colored cannula, and we prefer to administer it through largest possible and preferably distal most vein. Avoid cannulating over the joint. Slow IV push with running saline via 3-way is one thing that we need to keep in mind. If diluted in normal saline, its stability is for 24 hours at room temperature. Some people tend to dilute in 100 ml NS also and give over 10 minutes. But the recommendation is to give slow IV push with running saline. And the dose is usually capped at 2 milligrams because beyond that, at later doses, it results in cumulative dose limiting toxicities. And it is given at weekly and 3-weekly schedules in different regimens. Now, this is how the vial looks like. It's a clear solution. It is preserved at 2 to 8 degrees Celsius. Now, I would recommend all students to read clinical practice guidelines for chemotherapy extravasation and also IV cannulation or IV lines from ESMO EONS clinical practice guidelines. Now, the toxicities are constipation, jaw pain, neuropathy, which is the dose limiting toxicity. Commonest of neuropathy is sensory, followed by motor, then autonomic. It also causes SIADH, vestibular nerve damage, optic nerve damage, and more importantly, it is a non-DNA binding vesicant. Especially when we are administering as slow IV push, we need to be very cautious, train the nurses properly, and renal dysfunction does not require any dose modification. Hepatic dysfunction, yes. This was one patient whom I had come across during my residency who had bad extravasation injury because of vincristine extravasation. Now, it's the same patient. Now, let us look at a different case. 72-year-old male, MRI brain showed presenting with CNS symptoms. MRI brain showed right temporal lesion. Surgery revealed grade 4 glioblastoma. IDH wild type, Ka67 was high. Now, this patient is planned for CTRT followed by adjuvant therapy. Here, the regimen of choice would be temozolomide concurrent with radiation and then with adjuvant therapy. We know that temozolomide again is a synthesized alkylating agent. Now, one thing that we need to remember about temozolomide is that it is a prodrug which is converted to MTIC upon entering into the cell. There it forms a methyl diazonium ion, which is a positively charged ion, just like how platinum is converted into a positively charged ion. Now, this positively charged ion has high affinity to nucleophilic nitrogen atoms of guanine or oxygen atoms of guanine. It usually binds to N7 residue of guanine, O6 residue of guanine, or N3 residue of adenine. Now, based on where they bind, the DNA repair mechanisms take over to repair the DNA upon damage by the temozolomide. So, MGMT is a key enzyme. Methylguanine methyltransferase is an enzyme that repairs the areas where the temozolomide binds to O6 residue of guanine and thereby causing DNA repair and again promoting the cell proliferation. Similarly, mismatch repair repairs the areas where there are double strand breaks, while base excision repair acts where there are single strand breaks caused by the binding of temozolomide. Now, we need to remember MGMT because MGMT promoter methylation. Basically, what this means is every expressing gene before its sequence in the DNA has a promoter region, which upon methylation inactivates this promoter region and thereby reduces or stops the expression of that particular gene. Now, MGMT promoter methylation results in inactivation of MGMT gene, thereby enhances the effect of temozolomide-induced DNA damage. Now, the testing for MGMT promoter methylation is recommended for patients who are being prescribed temozolomide in oligodendroglioma, glioblastoma, and it is tested through methylation-specific PCR, which is commonly used, targeted NGS, methylation-specific multiplex ligand-dependent probe assay, and IHC. Now, this is a example report where there is a cutoff value of 50%. There is a value of 20% methylation that is mentioned. When it is done by PCR, a cutoff kept is usually 50%. Anything more than 50%, it means that there is MGMT promoter methylation, which means that temozolomide is more likely
Sorry to interrupt, sir. Requesting you to conclude. 30 seconds remaining, sir.
Yeah. So it is available at 20 and 100 milligram capsules. Parameters to monitor are the ones which we usually monitor for all alkylating agents. One thing that we need to keep in mind is the risk of pneumocystis pneumonia, which has higher incidence in GBM, and when used along with temozolomide, it causes lymphopenia, and therefore the risk of PCP is higher. So concurrent schedules, we need to use trimethoprim sulfamethoxazole along with temozolomide. Then the other regimen that we use in glioblastoma is bevacizumab irinotecan. Bevacizumab, we know it acts by binding to the VEGF-A. Basically, VEGF-A and VEGF receptor interaction results in promotion of angiogenesis that promotes cell proliferation. Now it is available at 400 and 100 milligram strengths. Biosimilars are available at 300 milligram strength also, stored at 2 to 8 degrees, diluted in 100 ml/s, administered over 90 minutes. We need to give antihistamine pre-medication to prevent hypersensitivity. This is about biosimilars. I will skip that. But common toxicities that we need to keep in mind with bevacizumab are hypertension, venous and arterial thromboembolism, proteinuria, GI-GU, GI perforation, GI-GU fistula, and hypersensitivity.
May I interrupt Dr. Supreeth?
Yes.
Almost all drugs are well covered, but as we are on time, it is 252 minutes exceeding the time. And irinotecan is well covered by Dr. Suti in the last GI case discussion.
Yes.
So within 30 seconds, please conclude bevacizumab, and we'll go on to the question answer session.
Yeah, so bevacizumab requires does not require renal dose or hepatic dose modification, but we need to keep in mind that it itself will cause proteinuria. So in patients who develop grade 3 proteinuria, which is nephrotic range proteinuria, the usage is not recommended. And this review article is good, but one thing with regard to irinotecan that we need to keep in mind in CNS tumors is, especially when the patient is receiving drug-inducing anti-epileptic agents like phenytoin or phenobarbital, we need to reduce the dose of irinotecan. And with this, I conclude my presentation. I thank Dr. Praveen, our final year DRNB resident, for the images of drugs, and also Akhil sir for his kind guidance. Thank you.
I sincerely thank Dr. Supreeth, because I'm sure this session will be extremely useful for many students who are online and who will watch this later as well, because you have covered almost all important topics, particularly the viral strengths, the precautions, and the vesicant properties, which are really necessary when we are doing the practice. So I thank you, Dr. Supreeth, and we'll move on to next session. So now I'd like to invite our expert examiner for today, for Viva, Dr. Professor Vijay Patil, who is consultant medical oncologist at PD Hinduja Hospital in Mumbai. And we know that Dr. Professor Vijay Patil is we know that Dr. Vijay Patil has established many standard of care regimens in head and neck cancers. So today we have two examinees with us, Dr. Praveen Kumar DVM, who is from Shankara Cancer Hospital, Bangalore, and Dr. Pasham Rajesh Kiran, who is a third year DRNB student at Indo-American Cancer Center, Hyderabad. So welcome, Vijay Patil, sir.
Okay. Hi, Pradeep. What exactly I am supposed to ask them? So, are there any formatted questions we'll be asking, or
Sir, you have seen the two quiz presentation that has happened in
Yeah, I heard
LMS.
both the questions.
So, if that case is being presented by these students, what would be the questions you would ask them? So, regarding DCF, along with that, there are some questions mentioned in the chat box. I would interrupt you in between, sir, and I'll take that question, sir.
Okay, and how much time we have for this discussion?
So, for we have Himanshi. Can you tell the time we have?
40 minutes, sir.
Oh,
20 minutes.
So let me start from the basic.
Right, sir.
So let's say that T2 N0 M0 tongue cancer is seen by a surgeon, and he is there in the multi-tumor board. So what would you do? And I forgot the name of both the residents. Can you just remind me, Venkat? What were the names?
Sir, Dr. Vijay.
Dr. Vijay, and the second is?
Dr. Rajesh.
So Vijay, this first question is for you. Okay, so it's a T2N0M0 CA tongue, and your surgeon is seeing the case, and it is in a multidisciplinary tumor board. What investigations would you ask for this patient? Vijay, you can take the question.
Dr. Praveen, sorry. Dr. Praveen.
Dr.
Dr. Praveen, are you there?
Yes, sir. Yes, sir. Good afternoon, sir. I'm Dr. Praveen from Shankara Cancer Hospital. So T2N0 tongue. So tongue is generally an aggressive cancer, and we will consider CCT. CCT of the head and neck will consider to first to see the extent of the lesion.
Okay, I'll stop you here. Whenever you get this question for any cancer, you'll always classify the investigation like those done for diagnosis, which in most situations will be biopsy, those done for staging, and those done for general fitness. So let me say that here biopsy is already done. It has come commercial carcinoma grade 2.
Yes.
Why did you select CCT and not an MRI? It's okay, Praveen. If you don't know, you just tell me. I don't know. I'll answer for you.
Yes, sir. CCT will give us extra information, but MRI also can be considered because if it is for soft tissue DNA.
Correct. So the standard answer which is expected by the most of the head and neck oncologist here is, if it's a soft tissue lesion, you want to do an MRI so that you have proper delineation of the soft tissue. Again, you come to know the perineal extension of the tumor also. If the tumor is like in the buccal mucosa or near the bones, then you want a CT scan. In situations where like nasopharynx is involved, there's a bone also involved, and there can be chances of neural invasion also. There you want both imaging, CT scan also and MRI also. Now, one question. Let's say this was T2N0 buccal mucosa. What is the instruction which you will ask when the CCT head and neck is done?
We will ask for puffed cheek CCT, sir, to look for.
Yes, you will ask for puffed cheek CCT. So let's say, what should be the plan in a T2N0M0 patient? What should be done?
Initially, upfront surgery should be considered after discussing in the multidisciplinary tumor board, and following which, based on post-op histopathology status.
So what should be the surgery you should be doing?
Wide local excision of the lesion. And ipsilateral supraomohyoid neck dissection, sir.
Correct. So don't forget that according to the N0 trial, especially most of the patients in that study with 85% tongue, a supraomohyoid neck dissection has to be done.
Yes.
Okay. Let's say that in the supraomohyoid neck dissection, you get 2-3 lymph nodes which are positive. Okay. And the margin is clear. Now what will you do?
And still it is T2 lesion, sir, post-op.
It is T2, but 3 lymph nodes are positive. Ipsilateral.
Based on that Bernier and Cooper et al., I will consider adjuvant chemoradiation, sir, concurrent chemoradiation for this patient.
Okay.
Based on.
Okay. So there is one catch here. You will come to know if the center has a frozen section. You'll come to know that the 3 lymph nodes are positive. Okay, in a supraomohyoid. If you get any lymph node which is positive, your surgeon needs to convert into a modified Radical neck dissection.
Neck dissection.
Okay. Yeah. So that
Yes.
one point you must always remember.
Yes, sir.
Second, okay. So what are the indications according to the meta-analysis done in 2005, which was a combination of the ERTC and RTOG? Which two indications will you want to give concurrent chemotherapy?
Positive margins and extracapsular extension, sir.
Okay, so it's positive margin and extracapsular infection. The evidence for giving chemotherapy for more than 2 lymph node positive actually comes from a large meta-analysis which was done about 10,000 patients, was published in GCO, where more than 2 lymph nodes, you saw that you could
And
give concurrent chemotherapy. So let's come
yes, sir.
to the question of concurrent chemotherapy now. What investigations will you ask for before suggesting the concurrent cisplatin in this patient?
Complete blood count, liver and renal profiles, and I will ask for ECG and 2D echocardiogram along with the viral serology markers HIV, HPCG, and HCV, and I will ask for pure tone audiogram, baseline pure tone audiogram. I will ask.
Fantastic, fantastic. Let's
Vijay
say
sir,
that the way
sorry for the interruptions. After 5 minutes, we have got this slide deck, sir, which have got 20,
okay,
21 questions, which are
okay,
most commonly asked questions in Viva. So
okay,
if students, you can direct those questions to these students, and if they can ask and
okay.
we can explain
No,
them.
okay. So give me just 1 minute. I'll just finish in 1 minute this early, yeah, and then we'll go to that part.
Sure,
So
sir.
let's say that all of these were normal, and you want
Yes,
to
sir.
give 40 milligram per meter square of cisplatin. What is
Yes,
the
sir.
amount of hydration you want to give before the cisplatin and after the cisplatin? And what would be the electrolyte corrections which will be given with it?
So I will pre-hydration. I will consider at least um,
Okay.
one.
So
Yes,
don't
sir.
worry. Please read. There is different hydration which is given for 40, different given for 75, different given for 100, which varies from 2 liters, 3 liters, and 4 liters. You need to know that. You also need to know the potassium and magnesium concentrations which are added in this. Alas, so we'll stop here and we'll go for that PPT which Venkata wanted to show.
Miss Himanshi, can you move on to the next slide, please?
Oh, who is the next person? Praveen and?
Kiran,
Dr.
sir,
Rajesh.
myself.
Dr. Rajesh Kiran.
Okay,
Good evening,
Rajesh.
sir.
Yeah. Good evening, good evening.
Yeah, next slide, please, Mr. Himanshi.
So doses of drugs in DCF, 75 milligrams per meter square for docetaxel, and cisplatin is also 70 milligrams meter square per cisplatin, and 1000 mg per meter square 5-fluorouracil, sir. In modified dosage can be given up to 40 to 60 milligrams meter square.
Okay. Wait. So you said 75, 750, and 5,000?
Yes, sir, for 4 days.
So let me remodify the statement. Tell me what were the doses of TPF which were used in tax 323 and 324 regimen?
75%.
So I'll tell you where you made a mistake. The doses were 75 dosi, 75 cisplatin, and 5-FU tax 323 and 324 was 750 milligram per meter square, day 1 to day 5. Now, when you use cisplatin and 5-FU alone, that is the time when the dose of 5-FU jumps to 1000. Okay. Can you just show that in the next slide? Okay, no, this dose of 1000 is incorrect. This is not in accordance with tax 323. Okay, so just recheck this. Venkata, can you just check on the internet? The doses here
I'm checking.
75, 75, 73. Yeah, tax 323 gave 750 milligram per meter square. Okay, what are the precautions? Okay, can we move to the next slide? Yeah. Yeah. 5 received NACT on CTIT weekly cisplatin. Okay. Rajesh, you want to take this? Praveen, you want to take this?
Yes, sir. The, so now he has already received 3 cycles of NICT and he is on weekly cisplatin 40 mg per meter squared. Now tinnitus, I will again do pure tone audiometry to check what is the current status of the hearing loss.
Correct. Correct. Now, tell me, how common is tinnitus on weekly cisplatin? Is this a common situation or it's an uncommon situation?
With weekly cisplatin, it is uncommon, sir. We will usually finish before cumulative dose.
Correct. Correct. With weekly, this patient may have got it because you may have given 2-3 cycles of cisplatin as NECT, 75, 75, 75, and then because of that, he probably might have got it. Can we move to the next slide? Okay, so can you tell me how do you classify hearing loss according to CTCAE? Which frequencies you check and how do you see it? Hello?
We lost you
Yes.
in between.
Move to the next slide. I think it's there on the next slide for you to see.
Himanshi, can you give me the control or can you move on to next slide, please? Miss Himanshi.
Dushan, can you move to the next slide?
So that what is said is correct. Just go back. The 25 decibel at 3 contiguous frequencies. My question is, which are the frequencies which you look according to CTC for hearing loss?
High tone, low tone, high frequency, low frequency.
Any idea?
We will see in high frequency.
No. So which are the, what I'm trying to ask is, what you're saying is correct, that you want to see in high frequencies, but which are the frequencies which you will see? Go back to that slide. Previous slide. Previous one. The one where there is a graph, where the graph of this was there. So you see at 1 hertz, 2 hertz, 3 hertz, 4, 6, and 8. Just go back. Just go back. Go back to that. Go back to the. So you look at 1 hertz, 2 hertz, 3 hertz, 4 hertz, 6, and 8. Okay. And what you
Yes.
need is you need to have a baseline for comparison. And according to that baseline for comparison, if you get 25 decibel loss, which is averaged over 3 consecutive frequencies, then you would say it's at grade 3. Okay. Are we clear?
Yes, sir.
Sir, sorry,
Yeah.
shall I share the screen so that there is a better sync?
Yeah, no issues.
Yes, sir. Just give me a second.
Yeah.
Because these questions I made so that there is a more discussion on practical aspects. So I thought I would do it myself.
Yeah.
Yeah, so this is the next question.
Okay, so now let this question be taken by Rajesh. So Rajesh, you gave first cycle of docetaxel and the patient complains of backache and breathlessness. So what is this likely to be?
The breathlessness might be due to capillary reperfusion syndrome, sir, due to
Okay.
accumulation of fluid.
Okay. What else?
For this, you need to give steroids post-treatment docetaxel at least for 3 days, starting from 1 day before starting docetaxel.
So do you think really this is capillary leak syndrome? How much time it takes for the capillary leak syndrome to happen in after docetaxel? Is it immediate or it happens after some time? So let's say that you had given paclitaxel to this patient and on paclitaxel the patient started complaining of breathlessness. you will suspect hypersensitive reactions. Na? One of the first, see, on docetaxel, if the patient gets breathlessness, there can be multiple reasons. One of the first thing you will suspect is hypersensitivity. It might be a
Hypersensitivity.
cardiac issue also. It may develop a pulmonary thromboembolism also. Those things also have to be kept at the back of your mind. But one of the first things which is the most clinical sound thing to do is to check for hypersensitivity. So let's move to the next slide. And can you tell me what would you do if the patient develops hypersensitivity on docetaxel?
Steroids, sir. Antihistamines and steroids.
But immediate management. Patient is having docetaxel. What will be the immediate management? That's what Dr. Vijay asked.
You got a call from the sister that the patient is having this. What are you going to tell the sister that by the time I come, you give this injections? So
Hydrocortisone and Neville, sir.
So you want to give hydrocortisone and Neville. Okay, fantastic. Now let's say that after hydrocortisone Neville, the patient settles. Okay. So patient settles after half an hour. So now what would you do? This was a transient flushing the patient had, slight amount of discomfort, no major fall in the blood pressure, no major respiratory distress. You gave the sister gave Avil and hydrocort, and by the time you reach, the patient is already settled. Now what would you do? Will you restart or you won't restart?
Will restart.
So in general, if it is grade, if you it is grade 1 and grade 2. In grade 1 and 2, you won't have more hypotension. Hypotension is not there. Desaturations are not there. You would restart. Okay. Now, when you restart, your infusion rate should be half of what was there previously, and you need to be around the patient when you restart. Let's say the patient you restarted again had a hypersensitivity. Then what would you do?
We'll discard the medicine, sir.
And now you restarted the medicine, again had a hypersensitivity reaction.
We'll stop the medicine, sir.
Yeah, we will stop the medicine. Okay, let's say that this patient had multiple lymph nodes which were positive, and you have to give some sensitization, desensitization, and your boss says that, okay, tell me a way how we can give docetaxel to this patient. Then what would you do? So the guidelines say that you stop, but for some reason you want to give the docetaxel to the patient. What are the 1 or 2 ways you can give docetaxel in this patient? Praveen?
Sir, we can start in a 2-way. We can start Dexa drip also along with the docetaxel. Very slow.
Anything else? Would you want to change just the brand of docetaxel or the formulation or not the brand formulation?
Docetaxel we can use.
Yeah, you can try for other. Yeah, so you can try for other formulation of docetaxel in which the polysorbate is not there. Or let me say that your boss is like me, who says that no, you have to give the conventional docetaxel only. What else you can do? Quick, we need to move to the next questions. Have you heard about desensitization protocol? Desensitization protocol. Muthu Vidappan answered correctly. You can do desensitization. Some other day, we will talk in depth about desensitization and how it needs to be done. It's very important in GI tumors when you have to give Folfox, because for oxaliplatin, you don't have a substitute. So let's move to the next slide. Okay. Now, so let's say that a patient is a elderly gentleman, is a CA larynx, and he has cardiac comorbidities. So you cannot give cisplatin, and you don't think he will tolerate docetaxel also. So you are planning him cetuximab CTRT. Listen to the question clearly. His radiation is starting from 7th March. So tell me, what will be the first dose of cetuximab, and when will you give it?
We should, the first dose of cetuximab is 400 mg per meter squared, and we should start 1 week prior to radiation, starting radiation.
Fantastic. So if it's 7th March, you will start 1 week prior, to 20th of Feb or 1st March, you want to give the cetuximab. Now tell me, why do you give cetuximab 1 week prior? And why don't you give, why nepotism is another molecule which is given as a EGF? You don't start nepotism 1 week prior. Why do we start cetuximab 1 week prior? And why do we use a dose of 400 milligram per meter square? Okay, the answer is for that question is normally, yeah, Praveen, you are answering. Tell me.
No, sir.
Rajesh? No, that's okay. You don't know, that's okay. Just tell me. See, in exam, if you don't know, just tell I don't know. Do not waste time going hunting around the bush. You reduce the probability of the next question coming in. So the answer is very clear. You give a high dose of cetuximab because cetuximab has very high affinity with EGFR. The first saturations, correct. Someone answered also. Has a high volume of distribution, and that's because of high affinity. So initial saturation which happens is of the skin. The next saturation which happens of the liver, and then once these two are saturated, then only the drug goes to the tumor, and that's the reason why this mechanism would take roughly around 4 to 5 days. That's why we do it 1 week prior, and the initial dose is on the higher side. So which electrolyte imbalance is commonly seen with cetuximab, and you need to worry about it?
Hypomagnesemia is
Very
commonly
good.
seen with.
Very good. Hypertension is commonly seen with cetuximab. Okay, very good. Can we move to the next slide? Okay, so let's say you have a locally advanced borderline operable buccal mucosa cancer. He has received first cycle of DCF, and what is the discharge advice you are going to give to the patient?
I just,
Chalo, Pasham, you take this question.
sir, antiemetics, DEXA, and peggrafil, sir.
Antiemetics, DEXA, and peggrafil. Okay. Okay. What else?
Any precautions you would tell?
So, what are the common side effects of DCF which you are uh, uh, expecting in this patient?
Prophylactically, you can give antibiotics when you're giving docetaxel.
Okay. Okay. It is not shown to be of much use in Indian settings, but okay, that is one of the things which was done in taxi 23 and 24. What else? So let's put this, whenever you get such question, put it in parts. One is, this is a multi-drug regimen. You give dosi and cis on day 1. Okay. Now, if you are given dosi and cis on day 1, cis-related antiemetic, anti-MSX is for 5 days. Am I correct?
Yes,
Acute
sir.
is given 24 hours. Delayed is for next 3. So actually, if the patient was admitted for 5 days, cisplatin-related anti-emetic chances are less. You have been giving 5FU daily. Now the day 5FU you started on day 5, so it will end on day 6. The patient will get discharged after day 6. Okay, so there is very limited role of giving additional anti-emetics in this situation unless the patient is complaining of anti-emetics. The
Okay.
thing is, what you're worried about is that the patient would have a neutropenia. So the first prophylaxis which you will think about in this patient is giving a GCSF prophylaxis for this patient. The second thing is there are chances that this patient would have infections. Now in TAX 323 and 24, they get ciprofloxacin prophylaxis to the patient. But the reason why I showed it does not work in Indian setting is because in our analysis of DCF related side effects, we saw that they were not really gram positive, they were gram negative. So I'm not sure how much useful that prophylaxis is, but it is given in literature, so you're very well justified in saying antibiotic prophylaxis. Would you want to give antithrombotic prophylaxis to the patient? How to decide whether you want to give antithrombotic prophylaxis or not to the patient? So the answer is you will do a Khorana score calculation for every patient who undergoes chemotherapy with you, and if the score is on the larger side, you will have to give antithrombotic prophylaxis. So you have antiemetic, anti-GCS, GCS prophylaxis, antithrombotic. Now next are precautions which this patient need to be taken. The precautions have to be explained in terms of diet, in terms of modification in lifestyle, in terms of social isolation, in terms of water intake which the patient is going to have, in terms of exercises, what the patient is going to talk, in terms of what work, how he's going to manage his work, and you are supposed to explain him what are the emergency signs and symptoms which happen, like fever, how much fever, how many vomiting, how much diarrhea, then he has to come to the hospital. So any chemotherapy regimen, you need to advise the patients in all these headings: antiemetics, GCSA prophylaxis, thrombotic prophylaxis. If it's a stage 4 and it's bone medicine, bone prophylaxis, then dietary modification, water modification, lifestyle modification, social isolation, and which are the emergency signs and symptoms. Are we clear?
Yes, sir.
Yes.
Yeah.
Yes, sir.
So let's move at the next question. Yeah. So now it's a 43-year-old female, oropharyngeal squamous cell carcinoma, planned for CTRT but cisplatin ineligible. Okay. First, let's discuss. When you see this 43-year-old female with an oropharyngeal squamous cell carcinoma, what does comes in your mind? Praveen?
The HPV related or unrelated, first
Correct.
we are
This is a female, so there is a less likelihood that she would be a tobacco user. There's a good chance that she would be a HPV related. So in this patient, you want to know what is the HPV positivity in this patient, P16 positivity. Okay.
Yes, sir.
Now, just for completion, now don't answer this in your exam. This I'm just telling you for it. We have just finished a genomic profiling of oropharyngeal patients. In India, we have known that HPV associated head and neck cancers are on the lower side. Non-HPV associated head and neck cancers in India seem to be associated with something called as fusobacterium. And we'll see this coming in Nature in one month, but I'll just, because I was taking this class, so I thought I'll share this information with you. Now, let's say this is P16 positive oropharyngeal tumor, which according to the previous classification, is T3N2. Now and the patient wants uh, and the patient and she is cisplatin ineligible, which is unlikely at 43-year-old female to be cisplatin ineligible, which means that she might have some rheumatic heart disease or something of that sort, or some kidney issues, because of which, let's say, you are cisplatin ineligible. Okay. So what would you do for this patient now?
The trials of de-escalation failed to demonstrate non-inferiority.
What you are saying is correct. If it is cisplatin fit, you want to give cisplatin and radiation in this patient. Correct.
Yes.
The question is, she is cisplatin ineligible. So what would you do for this patient? So
I will plan for a
discuss.
concurrent. Yes,
So
sir.
what are the options in cisplatin ineligible? Supreet showed you a slide also.
Yes,
What
sir.
are the
First
options?
option. Yes, sir. Phase 3 data is available for cetuximab along with radiation.
So let me modify that statement. Phase 3 data is available for cetuximab, which is Dr. Bonner's study.
Moderator. Yes, sir.
But that was for cisplatin eligible patients. So you can extrapolate that data of cisplatin eligible patients to give it. That's A. Another option.
The other option is docetaxel as a radiosensitizer along with radiation.
Correct. So docetaxel data is for cisplatin ineligible patient. Another option.
Another option is carboplatin with or without 5-fluorouracil along with radiation.
So carboplatin, though alone everyone uses, the McKenzie analysis did show that radiation alone versus carbo plus radiation, carboplatin alone does not seem to have a survival benefit. So the option which used to be first is carboplatin 5-FU. But again, the data for carboplatin 5-FU is from cisplatin fit patients. I have used carboplatin 5-FU in some situations, but this is a very, very toxic regimen to give. You get a lot more mucositis with this regimen. Any other option you know? So we talked about docetaxel, we talked about cetuximab, carbo 5. Any other option? Rajesh? You can give nemotuzumab alone also. There's a study by Dr. Babu, which can be given. Okay, so let's say that patient is cisplatin unfit, and let's go to the question. And he says that the patient is concerned about the cost of cetuximab. What are the options? And he wants cetuximab. So what would you tell him about biosimilar cetuximab? Can you move to the next slide? So I would be critical in this. So biosimilar cetuximab, what we need to tell that this is very similar molecule to that in lay person. Okay, we have data in metastatic setting which shows that biosimilar and original cetuximab are similar. We don't have the data at present in the radiation settings to say that biosimilar and this cetuximab is similar. But it seems that if they are similar in metastatic setting, should have the similar amount of action in the concurrent setting. Okay, and you will take a consent of the patient in this situation. Are we clear?
I think the question is regarding when a patient is asking about the two similar molecules, that is biosimilar and original molecule. And when we need to explain to the patient, how we explain in a very normal terms. So if Praveen or Rajesh, if you can explain, that's okay. Otherwise, we would request Dr. Patil on how to explain to a normal person, non-medical person.
Yes, sir. Biosimilar is the one which has no clinically meaningful differences with the original molecule.
Yeah, Dr. Rajesh?
No
we have
idea,
only
sir.
4 minutes, that's why. Dr. Rajesh?
No idea, sir.
No, so no issues. So what you need to tell the patient is that whenever you are dealing with a biosimilar or bioequivalent studies, that there are two components to it: chemical composition or the molecular composition. Both the chemical composition with respect to efficacy, toxicity is similar. The second is, just because the chemical composition is there, it does not mean that you would have the similar clinical results. But there is a clinical study in which half patients were given this original drug, half patient were given biosimilar drug, and it showed that they had similar results. Okay, and you stop there itself. Okay.
Right, sir. So because you are PI of this docetaxel CTRT clinical trial, can you explain for students on what are the important aspects we need to look upon while monitoring what we usually don't do with cisplatin? So if we are using docetaxel as a chemosensitizer, what additional precaution we need to take to do?
So docetaxel we are giving in cisplatin unfit patients. So these patients are potentially weak and they get mucositis early, as opposed to cisplatin where the mucositis comes out of 5th week. Docetaxel expect the mucositis by 3rd week or by the 4th week itself. So these patients, when I see the patient, I first look at the weight. Second, I would take the diet history, whether it's taking adequate diet or not. Any suspicion that he's not taking adequate diet, I'm going to put a rice tube in this patient. Third, I'm going to look at his mucosa to look for mucositis. Fourth, I'm going to ask for pain because oral mucositis I can see, but if the patient has laryngeal primary, the doses will be concentrated around larynx. So I am going to ask for dysphagia. If the patient has dysphagia also, that means the patient is developing mucositis. Next, I am going to give 2 days of extra hydration after week 2 and week 3, every week after that, so that his fluid intake is maintained. So I would do those things in the when such patients comes to me. And you should not be afraid or be ashamed of stopping docetaxel if the mucositis becomes grade 3 by 3rd or 4th week. Even if the patient gets 4 or 5 doses of docetaxel, it is good enough. In fact, there was a study called RTP 203 in which they could give only 5 doses of docetaxel.
Sir, I just
Right.
have a small doubt here, sir. Sorry.
Yes.
Would you prefer the patient to be inpatient from week 2, week 3 when you give docetaxel, sir, for hydration or?
So I'll tell you, if I had my way, all CTRT patient would be inpatient after 4th week. CTRT is a pretty complicated treatment. We do not give the due diligence to that. These patients require a lot of care. We had done a study in Tata when the patients were sent outside, and we saw that we lose 30% of patients to aspiration pneumonia within 2 to 3 months. A lot number of your patients die and you don't come to know because of aspiration pneumonia. So you need to take care of the mucositis, diet, the dermatitis, the electrolyte imbalance in these patients. So the answer is yes.
Yes, sir. Very much.
Can we move to the next question, or Venkata, we stop here?
Supreet, how many slides we have more?
Sir, just 3 more questions. And
Yeah, 3 more questions, sir, and we'll take some of the questions from the chat box.
Okay.
And we'll end.
So one thing I'll just so the PCB regimen Supreet na, there are
Yes,
two PCBs, MRC PCB and RTOG 9802 PCB.
yes, sir.
RTOG PCB is 8 weekly cycling, 8 weeks, not 6 weeks.
Okay.
Okay,
Okay, sir.
so there's a break. That's the only thing I wanted to add to that. But Praveen, let's take this question. So it's a oligodendroglioma. You had given VCR, and the sister says that there's a swelling and severe pain at the site of PCR. So what do you do in this patient?
So first, I will see whether there is any swelling at the site of the.
The sister is telling you there is a swelling. Believe the
So
sister.
yes, sir. First, I will stop. I'll stop the infusion. Then so I will not take out the needle. I will aspirate the content as much as possible. And then I will see whether there is erythema or is there or not. Erythema or erythema is there or not. So
Let's go
if
step by
it is
step.
in this case,
You aspirate it. Next step, what? Which type of compression? The examiners will be interested in warm
Hot.
compression or cold compression, and
Hot
whether
to
you.
is usually we will consider cold compression, but it may be if it is because of increstin, we should avoid cold compression because hyaluronidase we have the antidote is hyaluronidase, so it will cause vasoconstriction, and hyaluronidase will not act if particularly in epiphotophyllotoxins and vincristins, we should avoid cold compressions. Other.
So in VCR, na, you need to give warm. Next, can you move to the next slide? Supreet has put that in the year. Do you want to give DSMO scream or anything?
No, sir. DSMO is not the antidote for vincristins.
Fair enough. Fair enough. So what I would request is, in your practice, if you get such extravasation, na, also take a picture of the hand and look for the movements of the hand.
Yes, sir. It's not audible.
So we are unable to hear you. Lost you temporarily.
Every third day to look for the picture of the hand. Anytime if you see that the functional moment is increasing, then what would you do? Rajesh, was I audible to you?
Now you are audible, sir.
No.
Okay.
Now audible.
Yeah. So So my question is, you will take a photograph of the hand, and you'll keep taking photographs of the hand every third day, and also looking at the distal functions of the hands. What would you do if, let's say, the distal functions of the hands are getting compromised, or the swelling on the hand is getting worsened, or there is a blackish discoloration which has started coming? And what are you suspecting in that situation? See, what you're looking at is necrosis, subacute necrosis. Another thing, what you're looking at is it causing any vascular or neural compromises? So sometimes the sister doesn't give this on the dorsum of the hand. It will give on the other part of the hand. Okay, so just let me show you when these things. So sometimes it might be given on this part of the hand. So when it's given on this part of the hand, you then need to send the patient to, if these things are happening, to a plastic surgeon. And as someone correctly pointed out, some plastic procedure like fasciotomy or something would have to be done for these patients. Okay. Now, do we have time, Venkata, to take the next question?
Yes, sir. We can take this question and move on to the chat box.
So 74-year-old male, grade 4 glioblastoma. Okay. Interesting. What would be the radiation dose in this patient?
Concurrent doses 75 mg per meter square.
Nana, radiation dose.
Radiation
I'm not asking
dose.
the dose of.
Yes, sir. So, great post-op patient, sir.
74 GBM post-op.
Post-op, we will consider 60 gray EBRT, we will consider, sir.
So understand, for elderly patients more than 70 years of age, there is an MRC trial which has compared, someone answered it. A low dose, which is like
Hypofractionation.
40,
Yes.
45 gray, finished hypofractionation in 3 weeks, that is good enough in this patients. Along with that, also you can give temozolomide. Now, one question: temozolomide would you give on Saturdays and Sundays? Yes or
Yes,
no?
sir. Yes, sir.
And with what prophylaxis will you give it temozolomide?
With trimethoprim sulfamethoxazole prophylaxis to prevent pneumocystis carinii infection when given concurrently.
Very good, very good. So let me ask you one question. What are the two side effects which are you worried about with temozolomide?
It is moderately emetogenic.
One, okay, done. You are not worried about emesis, you can give antivenom. Something which you should worry about, especially if she is a female. Somehow it has been seen that the long drastic neutropenias in temozolomide are seen in females. Okay, so neutropenia with temozolomide is seen in only 14% of the patient, and grade 3 even below that. But you need to be worried about neutropenias, and it carries a black box warning for LFT derangement. So also look at the LFTs at least 2 to 3 weeks apart. Okay, when you're giving continuity.
Yes.
Okay, with that we'll stop here and we'll let Venkata handle the further.
Yes, sir. Thank you, Dr. Praveen and Dr. Rajesh, for your answers. Let us
Thank you.
take opinion from Vijay Patil, sir, some of the questions that are posted in the chat box. So the first question is, some are interesting, some are repetitive. We'll take the non-repetitive questions from the previous sessions. The first question is about nivolumab. While it is able to saturate 0.1 to 0.3 mg per kg, the T cell receptors, why the trials have used high dose nivolumab like 240, 360, 480?
Okay.
Vijay, sir.
So what happens is whenever you do trials, you want to be successful. When the trials of nivolumab were designed, we didn't know immunotherapy would be successful or not successful. Let's say that you tried at a lower dose and then you don't get a success. Then you always think whether I should have tried at a higher dose. Now, the second thing is that traditionally we don't the phase 1 doses. Now only the concept is coming that we look at the efficacy and try to choose the dose. The traditional concept is higher the dose, more the benefit. So the traditional MTD models by Fibonacci models, 3+3 designs always kept on increasing the dose. Now that's the reason why not only nivolumab, many drugs you would see we just keep increasing the dose till the trough concentrations are achieved, and we use the highest dose, believing that a higher dose will give a better response rate. But this thing may not be uh, appropriate in targeted therapies or for immunotherapies or for metronomic chemotherapies. So that's the reason why whenever you design a phase 1, or you design a phase 1 basis on a receptor saturation data, animal data, in vivo data, the mouse pharmacokinetics and pharmacodynamics which you give. But you start with a very low dose. The first dose which you start as phase 0 dose, or the first dose which will start, the starting dose, is actually 1/10 of the LD dose, lethal dose, which you get in a specific species of mice. And then you keep escalating it. The first escalations are at around 100%, next are 68%, then 38%, and so on. So you actually keep on. So you would be surprised in nivolumab phase 1, the data they went up to the dose of 10 milligram per kg, and they did quite a bit of patients. But we always criticize the pharma, but here pharma looking at the trough concentrations and the Cmax data, they decided to go with a dose of 3 milligram per kg. So actually they had escalated up to 10 milligram per kg. Now the concept is coming up looking at something called as optimal biological dose or optimal effective dose, where according to dose you will see the effectiveness, but such phase 1 models are very few. And up till now, I am not aware of any drug getting an FDA approval with using such models. So understand the pharma company also has put a lot of money. So they don't want to use such a model which the FDA has never used and take the risk of FDA rejection. You or me also won't do that if we are in that situation.
Understood, sir. So there is one more question asking about cisplatin triple phase elimination. This is theoretical, so you can read about it. Paclitaxel infusion YN condensate very clearly explained by Dr. Supreet. Carboplatin YN 5% dextrose. You can give in NS as well. And it is also discussed in the previous week's discussion on the drugs which can be given in 5% dextrose. So we'll go to the next question, that is, can 5FU be given in the peripheral line in head and neck cancers? So let us say if it is DCF, what would be the preferable? It is peripheral or central? Vijay sir? Uh,
I have given in both ways, peripheral also and in central line also. In Tata, we used to get many patients who couldn't even afford PICC. So I have given it in peripheral line, but frankly, 24/7 infusions which are going for 24 hours infusion going for 5 days, there are high chances that the patient would twist his hand and would lead to extravasation. So I always feel that central line is a more safer way of giving 5 infusions.
Right, sir. Next question is regarding, it is interesting, about the replacement of paclicarbo in place of dosis. Is there any data and do you use in clinical practice?
So we had done a large retrospective analysis of head and neck cancer patients who had received NACT. What we saw was paclitaxel and carboplatin was inferior to docetaxel and carboplatin. And so as a policy, if patient is fit, we use docetaxel and carboplatin, saying that we had a data which Akhil also has presented it, and one of my colleagues, Dr. Uh, Kashyap, Kashyap had Lakshman Kashyap he's now in Pune, he's a medical oncologist. He had, during the COVID time, we had combined paclicarbo with triple metronomic chemotherapy, and we had seen excellent results. So if you're going to use uh, paclicarbo with a triple metronomic, you will get similar results to that of DCF. In fact, at present, there's a randomized study going on in Tata Parel and Tata Varanasi testing this concept.
I use it regularly, sir. I had your talk in FHNO meeting, and so it's very useful in the peripheral settings and in patients with the average borderline performance status. So next question is regarding is there any oral metronomic regimen in which capecitabine is a part?
So there are oral metronomic regimens which have been developed by Chinese for nasopharynx, in which capecitabine is a part. In fact, for me, today the treatment of nasopharynx is locally advanced. Nasopharynx is neoadjuvant chemotherapy followed by CTRT, followed by 1 year of metronomic capecitabine based on the JAMA data, 2 papers which we got capecitabine maintenance for 1 year in nasopharynx.
Right, sir. So, and can we give biomap only with RT in definitive setting for the treatment of locally advanced oropharyngeal?
Only biomap with RT I would use in very, very frail patient who is not fit for cisplatin, who is not fit for docetaxel. In those patients, I would consider using biomap with RT. There is a randomized trial, though small, done by Dr. Babu sir. So we have evidence for that.
Yes, sir. So we
But
completed.
frankly, if the patient is very frail, and if the hypopharyngeal uh, cancer, I would actually ask the patient to get operated, because the results of surgery in that case becomes much superior than biomap RT.
Understood, sir. So thank you for your time, and it's a privilege that students are able to directly interact with you and learn from you. So both the sessions, the first part where Supreet has explained about all the drugs, and Vijay sir has taken on the case and the questions together with the students. So I appreciate your time, and I hand over the session to Dr. Barnini Ghosh for further proceedings.
Thank you, Pradeep.
Thank you.
That was a wonderful in-depth discussion on the practical aspects. Thanks to Dr. Vijay Patil sir, Dr. Venkata Pradeep Babu Koyyala sir, Dr. Akhil Kapoor sir, Dr. Supreet, and our students, Dr. Praveen and Dr. Rajesh, for volunteering to be examinees for this session. Our next session will be held on 16th February, that is next Sunday, 2 p.m. onwards, and it will be on drugs used in lung malignancies. We will have as our examiner Dr. Ullas Batra sir, who is the co-director Medical Oncology and the Chief of Thoracic Medical Oncology, Rajiv Gandhi Cancer Institute, New Delhi. We will have as our moderator Dr. Aditya Sareen, who is Associate Consultant, Department of Medical Oncology, Sri Gangaram Hospital, New Delhi. We will be again having as our mentor Dr. Akhil Kapoor sir, who is the Professor, Department of Medical Oncology, Tata Memorial Center, Varanasi. And our speaker will be Dr. Sabina K. Chaudhary, who is Consultant Medical Oncologist, the Department of Medical Oncology at Rajiv Gandhi Cancer Institute, New Delhi. So before ending the session, I will once again encourage all the DM and DRNB students to volunteer as examinees for the upcoming sessions, as it will not only give you an opportunity to experience these mock fiber sessions, but it will also be a great opportunity to learn from the senior faculty members across the country, particularly the practical aspects which we need to keep in mind during the Viva examinations. And with that, I'll just seek permission from the moderator to end this session.
Thank you, Dr. Barnini. I declare the session as closed. Thank you.